So we're here to take a moment to talk about another research paper that I was able to find. Now the reason I want to talk about this research paper isn't necessarily for the specific things that it presents. It's more so for a concept that it speaks about that is a more succinct way of saying something that I've said for a while, that I've actually said in video form before. So it was in the first video that I did about cognitive biases, or the concept of cognitive biases, where I talked about the thing that I seem to have seen. So from an observational standpoint, what I believed that I had been noticing was many times in many realms you'll see somebody identify a phenomena, find a way to repeatedly interact with that phenomena so that they get similar results or consistent results, and then they'll create a story so that other people can do the same thing, so that other people can interact with that phenomena in a predictable way. Now, the paper that I'll link to below that presents this concept in a more succinct way is saying essentially that we will, in osteopathic manual therapy, have treatment models and conceptual models. Now the treatment model, the key concept there, or the key factors, are that it provides a way to interpret palpatory findings, that it prescribes treatment, and that it provides predictable results. So what you'll have falling under that category will be something like the Sutherland cranial model, something like the Mitchell model of sacral mechanics, something like muscle energy as a technique, on and on down the list, facilitated positional release, so FPR, things of that nature. They have a way to interpret palpatory findings, prescribe treatment, and provide consistent results. The paper then goes on to talk about conceptual models, and these conceptual models are essentially the way that we're going to describe the treatment models, or the mechanistic portions of the treatment models, which in the case of osteopathic manual therapy and many other manual therapeutic modalities are not necessarily keeping up with science. So the suggestion is that it needs to keep up with the most up-to-date science and have accurate descriptions of what's actually occurring, as opposed to just what we believe is occurring. So what often ends up happening, and this is what I've attempted to point to, is things will happen in a temporally related fashion, or things will be in similar locations physically. So if somebody's presenting with pain at the inferior costal margin, or common costal margin on the right side, some people will automatically say that there is something going on with the liver, or there's something going on with the gallbladder, if there is movement dysfunction there, and then there's pain at the same time in the right shoulder. Some people will use that as a viscerosomatic reflex, suggesting gallbladder issues. That's problematic because we're working from the outside of the body. We have no way to actually prove that. In today's day and age, with the technologies that we have, if there is a reason to believe from a palpatory sense that there may be a problem with an organ, then we would want to go ahead and have blood tests and images to further investigate whether or not there was a problem with those organs. And if the further investigation shows nothing going on with those organs, then what we likely have is a musculoskeletal problem. So essentially it rules out the organs. The reason I'm talking about that and using that as an example is to just suggest that many of the conceptual models that are utilized don't hold up when investigated. The one in the paper that I'm specifically speaking about is looking at sacral mechanics, or the SI joint. Understanding that the sacrum and the innominate, the relationship between them, you'll get about 2 to 4 degrees of movement depending on the individual. Then when you actually go ahead and test, so you image the sacrum prior to treatment, you treat immediately after, you take another image and nothing has changed, then when we're looking at that with an acceptable methodology of creating the image, an acceptable methodology of treatment, and we find that there is no change, what it suggests is that what we think is happening is not what's happening. Is something happening? Yes. So what you're essentially seeing is you're seeing some repeatable phenomena occurring that is just not what we think it is. And that's okay. We should be open to that. We should accept that. We should understand that the stories that we tell surrounding what we do may be incorrect, and when new information is presented, we should be willing to move on. What I will generally suggest is that we consistently change motion characteristics of a patient's body We don't know exactly what mechanisms are at play, but we can do it in a fairly clinically and anecdotally repeatable way. But when interrogated, the methodologies that we're using and the stories that we're telling don't match. And again, that's okay. So what I'm going to do here in a moment is I'm just going to provide a demonstration just talking about a possible treatment model that some people will utilize surrounding the pelvis and anterior and posterior rotations, and suggest why the story might be problematic. The treatment model may not be accurate to what it's saying, however, there is a repeatable and consistent result. So we'll go ahead and we'll take a look at that. Okay, so what we're doing is we're essentially going to describe what could be considered a treatment model. So we've had a brief discussion about this and the concept of a treatment model. What I'm going to be doing is demonstrating it, but then also attempting to show where it may be problematic, at least in speaking. So one of the very, very common things in many manual therapeutic practices is to look at the levelness or unlevelness of the pelvis, to speak about anterior and posterior rotations of the ilium or the innominate, depending on the terminology you prefer. So what you'll often see is people will identify the ASIS, they'll hook underneath and point their thumbs straight at one another. Now, the ASIS that is lower would be considered to be rotated anterior, and the one that is higher or closer to the patient's head is considered to be posterior. Some people will take it a step further and they'll actually test the innominate, right? So they'll do what they call an anterior posterior rotation, and often what you will see is you will see somebody contact the back of the pelvis and then the front of the pelvis, and you'll see them create a roll. Now here is where we initially run into a challenge. So what you're getting is people creating what they would consider an anterior rotation or a posterior rotation. The problem with this is that in the relationship between the sacrum and the ilium or the innominate, so the pelvis and the sacrum, there's about maximum 2 to 4 degrees of motion that is ever noted there. So there's motion, but it's about 2 to 4 degrees. For me to feel that, so if I just make a very general visual representation, 2 to 4 degrees would look something like that. I am probably not going to sense that motion. So what's likely happening as I create that anterior posterior rotation, what I'm really doing is, as I'm pushing the hand that's underneath the patient up, I'm probably feeling the motion of my fingers, the deformation of my skin underneath the patient, possibly a small roll of the pelvis more on the transverse plane. It's very unlikely that I'm accurately identifying motion in the range of 2 to 4 degrees to see whether or not that innominate likes to go anterior or posterior. What I will say though is that although there's an issue with that test, or even with a test such as using a leg rotation or hip flexion, right? Not necessarily a leg rotation. I call it a leg rotation because as I was trained, this hold would turn into what we would call leg rotation almost immediately. But for somebody to come in, palpate the back of the pelvis, bring the leg up, and then to say, oh, it doesn't like to go posterior. Well, what we have there is, and we say it doesn't like to go posterior on account of the fact that we may not get expected pressure on our hands where we're palpating on the posterior surface of the body. Now the problem is that I have a model that says it should do that, I should be able to feel the pressure, and it completely ignores the rest of the leg, the hip, the hamstring. It ignores essentially the erector mass, although the claim will be that it includes all of those things, because what you're doing is you're palpating. If all of those things are working appropriately as they should, you'll feel the motion of the innominate. Again, going back to the fact that 2 to 4 degrees is not likely clearly palpable, that possible range of motion. So what would happen is, in this case, I would have identified, and I did identify in this case, that the right ASIS is lower, or closer to the feet, further away from the head. So then what I would do in a prescriptive sense, so we've got the concept that we can create essentially an understanding of palpatory findings. So if we're talking about those treatment models, the understanding of the palpatory findings is that although my tests are flawed, I would consistently have the finding that this ASIS is anterior, so this innominate is anterior, then what I would do in a prescriptive sense, so it provides an understanding of palpatory findings, in a prescriptive sense, I would go ahead and I would perform leg rotations on this side, which would end up looking something like this. So my attention and my intention are to move the innominate. So I use the leg for leverage, I go ahead and I palpate for bind and barrier, I use all these common terms, I move through this and I pay attention to what I'm finding, I pay attention to what I'm feeling, moving, until I believe that there's been a change. Now what I'll say as a practitioner is that I've palpated the change, I felt it change in my hands. What I will say as somebody who's been doing this for a while and had the opportunity to instruct others in it, I'm not so sure that you do feel the change, you just over time get an understanding of how much work it takes to make the change, because what you've done is you've done it, say 3 times arbitrarily, or 5 times, or 10 times you've done the leg rotation, and then you've gone back and checked and it either worked or it didn't. So over time, what you gain is an implicit understanding that it takes this much work to make the change. I don't know that you feel it as accurately as you claim you will feel it, but we go ahead, we go through our leg rotations because that's the prescription. We find the ASIS that is down, or the innominate that's rolled anterior, and we take the leg up in the hip flexion, we use it as leverage, and we go ahead and do our leg rotations to posteriorize the innominate. We come back in, we check, and what we will usually do, whether or not it's actually changed, is we'll essentially usually convince ourselves that it's more level, right? Now, I may be prone to that at this very moment. Now, if it isn't level, right, if it doesn't level out, so I've taken that anterior innominate and I've posteriorized it, if it doesn't work, then the next prescription that many people will often be trained to do is go to the other leg, perform a leg rotation on the other side, feeling for bind and barrier, and then lo and behold, what you'll have is a more level pelvis. What I will say is that I don't know that it's working on the actual anteriorization or the posteriorization of the innominate. There's a lot of things involved. There is gluteal tissue, there's erector mass, there's neurological phenomena happening as I'm very gently and respectfully moving the patient's leg through that leg rotation. Something is happening, but it's probably not anteriorization or posteriorization of the innominate, because again, as we've talked about, as we've mentioned, there are flaws with the concept, right? 2 to 4 degrees is not something that we're going to feel. Again, 2 to 4 degrees maybe looks something like that. It's not something we're going to feel accurately, especially in the context of the much larger movements that we're performing, whether it's the short lever test on the pelvis or using the leg as long leverage. But what we will usually get through an unclear mechanism is an alteration in either static level or dynamic motion through the region. Our attention happens to be on the ASIS, our belief happens to be surrounding the innominate moving in relation to the sacrum. What we get is a consistent and repeatable result, but mechanistically we may be off. So what I'm hoping to do is take this and talking through this and showing this to provide a greater understanding. You may have a repeatable result that's consistent, but it may not necessarily be what you think it is. And that's okay, as long as you're not going out shouting from the mountaintops and saying that it's definitely what you think it is. It may be something else. Again, that's okay. If you're getting a consistent result, that's the good part. Be careful what you ascribe it to.